The problem is that all the data we have on which we can use to do research with comes from patients. You could say whether they own it or not, they're the ones who provide it. So when they go to their GPs, through the hospital setting, through their treatments, through the outcomes of follow-up clinics, they're reporting data all the time. They're being asked questions all the time and things are being recorded. Now we have all that data across the NHS, but we haven't really been able to exploit that data well enough. There have been talks at the conference already around the use of big data analytics. Well, in the NHS, we have huge amounts of data on every patient who goes through the system. What we need to be able to do is to use it more effectively. And there have been some significant stoppers in the past 2 years which have prevented things happening, slowed things down, or have just muddied the whole agenda. However, when you talk to patients, they are very keen that we use their data effectively, to exploit it, to learn new things from it, but also to protect it and be responsible with it, as you'd expect. And the workshop we're running is to try and plug those two things together, to explain to the patients what data we have, what we're able to do with it, what we haven't been able to do with it, and ask what they think. Do they think this is correct? Or would they want to put more of a push to say we should begin to use the data? And if so, how would their control mechanism need to look? What would their involvement need to look like? What would they want to have in terms of a say about what data gets used or how it's used? So it's plugging researchers together with patients to try and explain what the problems are and to come up with some solutions. So the NCIN sits as a partner organisation to the National Cancer Registration Service. So the registration service collects data on individual cancer patients from hospitals, from clinics, from GPs and from treatments, brings that data and creates a cancer clinical record for every cancer patient. That record then moves into the intelligence network, where the identifiers are removed, but we can then use that to do complex analysis with. So recently you would have seen something called routes to diagnosis, where we've been able to calculate every single route to a diagnostic event for every cancer patient in the country for the past 6 or 7 years. And we can show good, bad, we can show where things have got better, got worse, and we can begin to demonstrate and influence change across the NHS. There's a huge amount of system-wide reluctance and fear, risk aversion, about using patient data in particular ways. So there have been various things in the press, in the media this morning. There were 3 separate stories: TalkTalk, Amazon, other organisations about data leakage and misuse of data. And the NHS has suffered with some of those things as well. However, when you talk to cancer patients, they expect us to use their data. They're giving this data as part of their treatment. They don't want other people to suffer the way they have suffered, simplistically. And we can use their data to show where good practice, bad practice exists and do something about it. So the patients expect us to do this, and yet the system as a whole is quite risk averse and fearful of doing it. So none of this will be solved unless we can activate that patient voice, to be very clear with them about what data we have and what the risks are, but particularly what the benefits are, so they can make a valued assessment and give us the support to continue to do what we want to do. The most impactful piece of analysis we did recently was routes to diagnosis, where no other country in the world has got near being able to do this. So for every person diagnosed in this country, we could tell how they were diagnosed and we could tell the pathway, that diagnostic point. We could also tell, for the different diagnostic routes, what effect it had on their outcomes, what effect it had on their individual experience that they reported. And you can see some really stark differences. So people who arrive as a first diagnosed through an accident emergency, through an emergency presentation, fare much less well. Their survival is much poorer than those who arrive through a more managed route. There's a simple message, which is if you can manage the routes better, if you can pick cancers up early and get the diagnostic point pushed further back, early diagnosis, patients' outcomes are improved, but equally the experience that patients report equally goes up. So it's a win-win. You diagnose people earlier, their experience is better and their clinical outcomes are better. More people live versus die. It's as simple as that. And it's activating the patient voice to make sure that this work, as an example, could continue, because it uses big data, it uses all their data. And without their support, there's a real danger that a lot of these pieces of work will stop. Okay, so all the analyses we do are all based on individual patient records. We can collate those up at different levels. So we can look for a particular cancer type. You could look at breast cancer. You could look at the profile of diagnosis and treatment and care and outcomes and experience for breast cancer. Or you could cut it the other way and look at it by geographic parts of the country, north versus south, rich versus poor. You can cut it by different ethnic groups. So you could begin to see, by looking at the same data in 4, 5, 6 different ways, you could begin to see different areas where improvement's needed, whether it's by a particular characteristic of the person, male, female, young, old, or whether it's to do with where you live, the geography, the deprivation, or whether it's to do with a particular type of cancer that you get. All that's only possible because we can access the individual patient records to begin to do these things, but we can drive change and effect change across all the different dimensions of those areas.